Today, my name is Nattawut Wanumkarng from Bangkok, Thailand. I have a great pleasure today that I have the chance to visit his famous clinic of Dr. Kashima, and we learn a lot from each other. And thank you very much again for inviting us. And I think. What we have seen today I will apply to use in our country, because Tommy did a very good example to be combined between the academic and service together, and he did really well and wonderful job, and I think he's going to be the great inspiration for the young generation of the ophthalmologists and oculoplastic around the country and around the world also. And today my talk that Tommy asked me to talk, I would like to share with you about my 19 years experience that I have worked with the patient with the tearing problem. And when I finished my fellowship in 2003, and I came back to Thailand and I start to do the lacrimal surgery by the endoscopic. And after my fellowship program, I never done an external DCR again, never. So in this talk, I will show you what I have seen and what I have learned, what the mistake, what the successful in the past 19 years. So when you are the oculoplastic surgeon, many patients, many doctors or patients have the problem of the tearing. They may refer to you for the tearing problem. In the beginning, 5 years, 10 years of my practice, I focus only on the surgery. The surgery only. I do a lot of the endoscopic DCR, many thousand cases, have learned a lot. So when you have the patient with the tearing, two categories. The first one is the true before. So the caused by the true obstruction. It could be from the upper tear duct system, middle part, or the lower part. So we call nasolacrimal duct obstruction. So the surgical correction gonna be easy. To me, it's very easy to do the surgery because we can do the endoscopic DCR very well with the flap suturing in 40 minutes and all done. The success rate is very high, about 98-99%. We cannot say 100%. But the other part of the practice, you may have the patient that have the problem come up with the tearing pseudo before, after your successful surgery. That could be the painful of the lacrimal surgeon. If you are the oculoplastic surgeon, I don't want you to be only the oculoplastic surgeon. I want you to be the lacrimal surgeon, lacrimal specialist, so you can do both really well, either surgical and medical treatment. So after finish the talk, you're gonna learn and I'm gonna show you how to approach with the surgical and medical aspect. So in the picture, the patient that come to us, may have the abnormal eyelid malposition, ocular surface problem. We put the Buffy filter, we saw a lot. And the eyelid margin disease, it's gonna be the major problem. Every time when you flip the eyelid inside out, we're gonna learn a lot. We're gonna see in the molecular level, we're gonna treat in the cellular level. So that's the concept of the talk today. So let's start with the surgical correction. When we try to perform the endoscopic DCR, I want we to have the two concepts. If we have the concept, we can do every case successfully. We need the concept. So how we get the optimal success for the endoscopic DCR? The first one is a bony concept. The bony ostium concept is very important initially. And after that, the flap concept. The bony ostium concept, the surgeon need to do the very adequate bony ostium, not too small, not too big. And second, and the flap concept. we try to do the flap approximation to be super good as the external DCR, because the external DCR have been done for more than 150 years, and the success rate is very high. It's about 95% for the gold standard. But nowadays, I would say endoscopic DCR is a gold standard, not the external DCR. So, for the ideal bony osteum, if you have the chance to learn when you do the surgery, you put the CD of the CT scan, put in the good software, especially in the Macintosh or the Windows, you can integrate the data inside. You can learn a lot from what we have done. In this case, I did a successful endoscopic DCR, and sometimes we never put the CT scan in the computer take a look in the 3D dimension. So in that one, it's a normal lacrimal anatomy, and the ideal ostium is going to be big enough, and the flap should be approximated in 360 degrees of the surrounding of the nasal ostium. But we can see this one is going to be look easy, but sometimes when we go inside the nose, the nasal cavity is so small. We are all ophthalmologists, oculoplastic. Sometimes the young surgeon not familiar with the very small space, so that gonna be lead to the failure of the case. So nowadays, if you download in the application in the Apple Store, we call complete anatomy. You can learn the anatomy by the application, by the digital anatomy. I will encourage you to try to do endoscopic DCR by the digital way. And you can learn about the frontal prostate of the maxillary bone. You can edit and see inside of the nasal lacrimal groove and see the anatomy and see about the relationship about the lacrimal fossa, lacrimal sac, lacrimal nasal lacrimal duct, and lacrimal bone, and the frontal prostate and the thickness and the relationship and the middle meatus and the ethmoid bone, uncinate prostate, and the acanthacy nasi. That's very important, and including the inferior turbinate also. Because if you are the beginner, you are the surgeon, if you be familiar with the anatomy when you go inside, you're gonna can control everything successfully. So this one is going to be very helpful and for the beginner. If you are this is the video show how to do the endoscopic DCR by the digital application. If you are a beginner because going through surgery, you can do the surgery like animation in the application, and this is pretty close to the normal one. And after removal of the frontal prostate, lacrimal bone, and some part of the uncinate prostate, we can see all of the medial wall of the lacrimal sac. And after that, we can approach and see the whole area of the medial area of the medial aspect of the nasal lacrimal sac. Okay, and this is I will show you about the simple conventional endoscopic DCR. In the first 5 years of that I practice, I start like this. I remove the lower part of the bone with the simple launcher. Some surgeons prefer to use a drill, but I think the simple way is the simple Carison launcher. It's a cheap technique and fast technique and very practical. And the lower 2/3, we divide the bone to be 2 parts. The first part is the lower 2/3, and the second part is upper 1/3. The lower 2/3 is so easy because when you open the C-shaped flap of the nasal mucosa overlining the middle meatus, you can see and you can use a Bowman probe. And the more challenging part is the upper 1/3. This is from the nasal nasal view, and this is from the orbital view. The second part that we try to remove the upper 1/3. In my current technique, I use a simple correction, simple chisel and mallet. By a couple time of the chisel and mallet, you can remove the upper 1/3 easily. And I gonna tell you about the 45-degree test, that how it helps to evaluate that and the adequacy of the bone layer. The bony concept. This is the bony concept. And 45-degree test is a practical test that I have used all the time. I'm going to tell you that it's very practical in a couple seconds to evaluate either both pre-operative and intraoperative and post-operative for the evaluation of the adequacy of the bone. So this is why 45-degree test. This is a digital. In the CT diagram, you can put the soft tissue in the CT, and you can use another figure that faded the soft tissue, so you can see the bone inside. That is the 45-degree test is used to evaluate about the if the new case, you can put the 45-degree test and check this case gonna be thick or thin of the frontal process of the maxillary bone. But in the failed case, you can use this one for checking if the previous surgeon can do the good job or not. In my series, a small series, I start in 2004 and I collect until 2014. We have the very good success rate initially. You can see about 97% of the 81% of the success. But on the second part of the practice, the success rate dropped a little bit up to 88%, and then it come up to 100%. I would let you know because every kind of the surgery, they have the learning curve. When you finish the fellowship program, you learn from our mentor. You do everything according to the mentor. Everything is so success. When you come familiar for a while, you try to do our own way. You try to do this way. Sometimes it's good, sometimes it's bad. So the success rate is drop a little bit. So after you learning about your failure, about your unsuccess, you keep changing and keep adapting. So the success rate come up and then not go down again. That's the way we learn. So in our practice, overall success is 92% in the first series, but all failed case is 80% need to be revived. I would tell you why it fell, because if you learn from the mistake, it's the best way to learn. This is the bone. This is adequate removable bone, but this is the inadequate. You see, this is the upper part of the bone have not been removed because sometimes the septal deviation, sometimes the nasal cavity is so narrow, sometimes it's so bleeding, sometimes the surgeon not familiar to remove the upper 1/3 of the bone, so that's why it's not adequate. But sometimes if you do not have the concept, you did not know intraoperatively that the bone is adequate or not. So how can we estimate the adequacy of the bone intraoperatively? I would divide to be like that. This is a 45-degree test. I divide to be 45 up and 45 down. This is a 45 up. This means we put the tip of the bone pole up. The 45 down we put to be down. And this is a 0-degree test. We put the bone pole to the punctum, to the canalculus, to the common canaliculus, and then we check the bone. Initially, if you are the beginner, you go to the anatomy department. You put the pen light to the orbit. You can see the thickness of the bone. You use your finger to palpate it. You feel the thickness. It is the most thicker part. But I found that Chinese people, Thai people, Japanese people, Mongolian people, they have the wide face, big of the maxilla bone. So most of the patient like that, not the thin face. They have the big thick bone. They get the more difficult. But the patient like Caucasian, Indian, or Middle East patient, they have the narrow bone. As the bone, this one is more thinner, so it got to be much easier. So prepare for the bony osteum for the approximation. This is a 45-degree test and at 0 degree. And you apply the tip of the bone probe. The tip of the bone probe pass from the punctum, canaliculus, common canaliculi, through the area of the medial aspect of the common canaliculi. If you remove the bone, this is the lower 2/3, this is the upper 1/3. If you pass the tip of this one to the bare area, this one, this area should be the bone that expect to be removed. This is the bone that we should be removed. Sometimes if you remove too small, that can be leading to the failure. So the first one, the 45 degree up. We start with this. This is a 0 degree. This is the 45 at 0 degree. This is a 45 up. This is the way to check intraoperatively if the tip could pass the bare area and hit to the septomucosa. That means the 45 up is positive. That means this bone have been removed. But if it not, could be stuck from this one. If the bone not removed, that this is going to be blocked. That going to be negative. That means the previous surgeon not removed properly. So that's a meaning of the 45 degree test, up test. This is showed you in the area. This is when we remove the bone and on the lower 2/3, and this is the area of the upper 1/3. And you can use in this one, if you are the beginner, you may think about this one is enough. You can do in the first part of my practice, I did not know this concept. So I can do the endoscopic DCR in very fast, 12 minutes, and then finish. I just open cut in vertical cut and then put the stent and done. I told my friend, oh, my endoscopic DCR only 12 minutes, but that's not super good. That's just fair. But if you want to be super good, you have to get the very good bony ostium and very good flap approximation. This is the video show you how to apply the chisel to your hand, and you put your hand and grab it steady like that. I not do like the ENT way. You let my assistant hold the camera, the rigid endoscope in the opposite side. That allow, and you keep the nasal cavity and let the endoscope in the infromedial all the time and less in the infromedial of the nose. And this is the area of the upper 1/3 that we remove. And you can see that in the 45 degree up test. If you check like that, in 2 seconds, you know that the bone in the upper 1/3 is so adequate. That's a good point. That's the final point that we are happy. So, but if you do not remove that, I would say you got 5 to 7% could be fail. Even though you get a very good opening, but without or with the flap suturing, they're going to be at least 5% and 4-5% fail from this this way. And after that, after we remove this one, we can make a vertical cut and we can do like a conventional. And the next step, I will show you the 45 degree down. This is a 45 degree up. Mostly we use this one intraoperatively to check the adequacy of the bone. Okay, next one, the 45 degree down to evaluate the lower 2/3 of the frontal process of the maxillary bone and to evaluate the scar tissue in the revision DCR. Because sometimes in some case that you have the failed case referred to you and you need this one to evaluate and you need to plan in your head. You can manage the revision case with the bone job only or with the bone job and the flap job. So that's very important to have the concept in your mind. And after you do 45 up, you put the proximal part of the bowman bone up, so the tip gonna be down. So we call 45 degree down. So this is to evaluate the adequacy of the bone on the lower 2/3. If you can pass the tip past the area of the removable bone, is called positive. If you could not, it's called negative. So in this one, it shows that the previous surgeon did a good job on the very good ideal bony ostium. That means positive. And that one is not good. It's named negative. So let me show you. If this is the case that have the previous conventional endoscopic DCR. This is called SUM syndrome. They have the still have the tearing, and when irrigation, they could be part because a tiny hole. They have the only a tiny hole in the upper part. So we can, when we do this one at 45 degree down, is soft negative. It means when you put this one, it feels soft and it could not be passed to the nasal cavity. That means the previous surgeon create the SUM syndrome and they have the lump, something like the pocket. So In this way, it's really easy. If you found that in this case, the 45 Dow is SOP positive, you can create by inject the numbing medication, make a vertical simple cut, and then rotate posterior flap backward. And then with the one simple flap suturing, you can create the really good approximation between the middle turbinate and the posterior flap of the lacrimal sac. So that could be way to correct the some syndrome easily. So the next one is a hard negative. Hard negative is mean when you put the 45 degree down, it's stuck to the bone. It's stuck to the bone. You cannot pass and very hard, not soft feeling. That means the previous surgeon did not perform a very good job on the bone and possibly a lot of scar tissue. So in this case, we try to put the bone probe down and they stuck a lot and very hard. You can see the whole scar tissue. We cannot see any tiny opening at all. So if you are the surgeon and the condition like this, you keep in mind that you're gonna be in a very hard time because a lot of scar tissue already happened. You have to perform the whole thing new one. You create the C-shaped flap. You're gonna see the very thick scar on this area. And I remove the scar tissue, the C-shaped flap, it's not that a simple nasal mucosa. It's gonna be the very thick mucosa. And when we open this one, we can see the very thick scar tissue, not a well organized lacrimal mucosa. So we have to do everything new time. So that's going to be a very challenging one. So in this case, when we perform the 45 down, it's so hard, and we try to check the up, is still negative also. So I need to do like the new case. We have to remove the bone on the upper 1/3 a new time and create a very good opening of the lower part of the medial aspect of the lacrimal sac and create a new one. That's the way that I use this technique to correct this one. And in this one, I use try to do the volume study on this one. The bone that we remove, we put in the saline like we did in the saline. Even okay, in the average, it's about average, it's about 0.32. That's an average that we can get a very good result. If you are the beginner, you can use this number for reference. If you take a bone only 0.2 or 0.1, that means the bone job maybe not that big. If you take a bone and you measure at 0.6, possibly that you take too much. And sometimes the bone may be too big, and sometimes this term the video can recommend. Sometimes this term about the surrounding of the tendon ligament, and sometimes this term about the orbicular muscle. So that's the concept that we use. By conclusion, the 45 degree test is a quick test, effective test that could be used intraoperatively in 2 seconds, either pre and intra and post-operatively, and use to evaluate the adequacy of the removable bone during the primary DCR, and could be used in the failed DCR very well also. That's the first part of my talk. And the second one, when you finish an understanding of the bone concept, the flap approximation concept is very important. In the old days, 20 years ago, no one in the world tried to do the flap suturing. Before me, there one of the Indian surgeon. He wrote an article in 2005, and he talked about the flap suturing. But the cases maybe only 20 cases, not that much. And he did not say about the detail of the how to perform the flap suturing. But I'm gonna tell you about the flap classification and flap suturing. This is a question that we have been always asked about. What kind of the suture that I use? What kind of the needle? If you are the oculoplastic surgeon, you have the concept of the needle. You have the concept of the suture. You have the concept of the material and the curve and the shape of the needle. I use this one. I use the spatula. I don't use the cutting. because the spatula needle, they have the sharp, that pretty sharp enough. They have the sharpness at the lateral part, so they can go through the nasal mucosa and lacrimal mucosa freely. And if you use the cutting or reverse cutting one, they're gonna drag. They have the possibility that you can drag the lacrimal mucosa or nasal mucosa and tear. But if you use the spatula, they're gonna be very stable and they're sharp enough to cut through. If you do the revision case, they have the sharpness enough to penetrate to the thick scar. And the 8 millimeter is a good number for the length of the needle. But if you use a conventional S24 that you use for the tarsal plate surgery or the muscle surgery, they are only 90-degree needle. They only 1/4. Not enough. When we do the job in the very narrow cavity, we need to bend it to be 180. If you don't have, you need to bend the needle like in the video, like this, so you can get the 180-degree needle. But if you order the S22, you already curved it already, and you can use your Castle faucet that you use to do the suturing for the pterygium or the cataract or the lid surgery, and keep practice for forehand grabbing and backhand grabbing. So the flap suturing classification, I divided to be 4 classification. The first one is anterior and posterior flap suturing, and the second one is the superior and inferior flap suturing. The third one is combined flap suturing, and the last one is isolated flap suturing. Most of them, 90%, I use this one because of it's very practical. And most of the time, the lacrimal sac gonna be the conical shape, and you go open this one. This one used in some occasion, like you have the distended sac, like you have the chronic dacryocytorhinostomy with distended sac, and then have the pus or the abscess inside. And this one combined between the superior, the inferior, and the anterior. It combined in the difficult case like a revision case. And isolated flap, it could be used in the SUM syndrome case. So let me show you about the video to do the anterior and posterior flap suturing. This is more than 90% that we use this one. When we create the bone job already, you just let the assistant hold the camera in one hand, and you use a forehand suturing. In the beginning, if I go to the rural area and do the 10 cases a day, I would do only one simple. But if I not in hurry, I'm gonna do 2 suturing. The first one in the upper 1/3, and the second one in the lower half, upper half and the lower half, and try to approximate between the nasal mucosa and lacrimal mucosa 100%. Sometimes I do continuous suture also, because the more you can do approximation of the nasal and lacrimal mucosa 100%, it's no risk of the bleeding and no risk of the nasal discharge. Because sometimes if you do the endoscopic DCR without the flap suturing, they have a lot of bleeding after surgery. They have a lot of nasal class after surgery. This is the video show. If you have time, you can do the posterior flap suturing. But the posterior flap suturing sometimes is not that easy because it's too posterior, and sometimes only simple anterior flap suturing that will be enough. And you can see the post-op ideal nasal audience should be like that. Should not be small, should be like this, because you can see the whole lateral wall of the lacrimal mucosa, and you should see the internal opening of the common canaliculi or wall of Rosenmuller. So this is the superior and the inferior flap suturing. This is just for showing you that we can create like that. But some occasional that we use like that, because if we're going to do like that, I want you to see the superior flap suturing. In this superior flap suturing, we apply this one to use in the difficult case. I will show you later. And when you try to perform the flap suturing, some of my fellows, some of my visiting ophthalmologists learn from me, and they want to try to do this one. Some of them can do, some of them cannot do because they are in rush. If you're gonna start to performing, you keep in slow and train your colleague to hold the camera very steady. And you tell them go in 1 millimeter, back 1 millimeter, go in half millimeter, something like that, and should not shaky. So you can perform really well. And the combined one is gonna use for the difficult case, and this is an isolate one that I showed you previously. If you have the sum syndrome like this, you create and you do the 45 down test and it's soft negative. That could not be passed. So you have the idea in mind that you get the very simple vertical cut and you can correct the revision. You can do in the outpatient way, not need to be the true general anesthesia also if you have the concept. But if you have the very thick scar tissue inside, sometimes we cannot do, like we have to do fully general anesthesia. For the revision, DCR for the fail, this is a challenging condition. If you are the lacrimal surgeon, you're gonna have the referral case for this is ideal. But if you have the concept, I divide the classification for the fail case to be fail from the side of the post-endoscopic DCR surgery and fail after external DCR surgery. Do you have any idea what the difference? Have you used, any of you still do the external DCR? Yeah. Do you have any idea that what the difference if we do intraoperatively after external DCR and after endoscopic DCR? Any different from the fail?
This what would be the causes of failure?
Yeah.
Why? In external versus internal DCR. I think probably for endo DCRs you get a lot more adhesions with the nasal, mucosa, because inadvertently that's why you try when you go in.
Right.
You try not to hit a lot of things.
Right.
You try not to incite bleeding because that can cause a lot of adhesions. For the external, it sometimes may be because when you are making your wounds, the external wounds, it can be a little bit too saggy, I think, and it then occludes the ostium, but that's how I'm thinking.
You are very smart. That I have found in my practice also. Initially, in the first 10 years that I practiced, I did not recognize this one. But if you are the surgeon, I do encourage you to record every video that you have done and keep in your library. Any day that when you take the video back and you take a look in the video that you have done, maybe good or bad, or the revision, you found something. You found something new. You learn by yourself. You learn by your mistake. This is the way that I learned from my mistake. I found that if the referral case fell from the endoscopic DCR, even though my failed endoscopic DCR in the beginner part of my practice, I found a lot of scar tissue on the nasal side, like you said. And so this is a very thick scar. And this is the bone, the blue part is a bone. As I told you, this ideal ostium should be big. But if the previous surgeon did not remove the upper 1/3, and this is the lower 2/3, that's not so good. And the surgeon disturbed too much for the scar tissue intranasally. So they have the bare bone. So the scar tissue encroaching. So in this external DCR, the surgeon apply for the orbital side. So sometimes they disturb too much for the mucosa of the lacrimal on the orbital side. So the scar tissue may have a lot. Then when you do the external DCR, you barely disturb the nasal mucosa. So the nasal mucosa on the nasal side should be pretty good, not that bad. That's the difference. So I will start the scar tissue. This is good to learn about how to correct them. This is the mechanism of the fail. If you do the conventional endoscopic DCR, you remove at the lower 2/3, like the first part of my practice. I remove only 2/3 and cut on the medial aspect of the leg, and then put the stent and boom, done. And then put the gel foam and done, and keep the stent for 1 month or 3 months. After that, it could be failed because I removed too much of the nasal mucosa. I will show you how mechanism, how it happened. Because this is the way that we remove too much and the bone. This is like a phenomenon of the stalactite and stalagmite in the cave. When you remove this one, the red area show encroaching of the scar tissue from top and down go together, encroaching and start to this one. If you put the tube inside, this is the way how the SUM syndrome happen. Once you keep the tube in, it's still good. When you keep the tube out and the opening here is so well healed, so you see the tiny. But if this one is so aggressive, this one can be totally blocked. So that this is a mechanism why and how the mechanism of the failure of the SUM happen after the endoscopic DCR surgery. Sometimes we found the very thick scar tissue. And this is the same video that we use to explain how to correct the SUM syndrome with the simple flap suturing. And this is a way the show how it's easy to correct this one. So the next one is a classification of the fail that from the external DCR. You can see that with the external DCR, the scar tissue is lost. This is more challenging. I can show you why it's challenging. Because when we perform the external DCR, most of the time we can remove the bone from outside, and we could not remove the bone behind the medial canthal ligament. The ostium from the external endoscopic DCR gonna be a little bit larger because we could remove. But the best way that you can remove from the external DCR is below the medial canthal ligament. But if you do the good job for the flap operation, you do external DCR, you could be fine. You get 95% success. But this is the difference between approach of the bony job between external and the endoscopic DCR. But this is the way it failed. When we put the tube out from the not good external DCR, total blockage happen. And so when we do the surgery, this is the way that endoscopic DCR we can remove the bone larger because the upper 1/3 could be removed. And this one I learned from the application. I learned from the digital anatomy. This is I can see. And okay, this is show the multiple failure from the external DCR with the very tiny ostium. You can see this is not the simple SUM syndrome because when I try to move the 45 degree down, I got the very hard block. So it's gonna be in this moment, I'm the surgeon. I know the inside gonna be tough because everything is so tough. So when I create the remove the scar tissue, I do to remove the new part of the lower 2/3. And when we found on the middle aspect of the leg, you see a really thick scar. If I do like this without the flap suturing, the scar tissue will rotate backward posteriorly. And certainly, if I did not perform the flap suturing on the revision case, in this case, gonna be fail again, like a multiple failure in this case. So we decide to do the flap suturing on this one and really strong one. So in this way, we can achieve this one. If you and after the suturing, I do everything that I could do, like put the tube, put the gel foam, inject the steroid, that could help. That in my practice I did not perform. I used to use the mitomycin C, but nowadays I did not use. I believe in the surgical success anatomy more than mitomycin C. But sometimes mitomycin C may help. But if you use the mitomycin C, don't use too long, more than I could not remember the minute. How many minutes, Tommy? 5 minutes, 3 minutes.
For 1 or 2 minutes.
Yes, you are right. If you use the mitomycin C and that too strong and too long, sometimes it destroy the mucosa. I have seen one time that the mucosa, they have the opening from the nose to the caruncle. That's because of put the mitomycin C too long. Do you use the mitomycin C, Tommy, in the revision case?
Some case.
Some case.
Yeah,
Some case.
2 or 3.
Yeah,
my career.
yeah, and this is show you a very tough one. In this condition, the scar tissue is a whole thickness from the common lacrimal mucosa and nasal mucosa. In this condition, it's gonna be a tough one. I gonna show you this condition. We can apply the combined flap. The combined flap is mean we try to create the anterior flap and superior flap. In many difficult conditions that I apply the superior flap is very helpful. I will show you after we remove the thick bone on the upper 1/3. You're not gonna see this thick bone in the Caucasian patient. You're gonna see in the Asian patient. In this is area that I found the scar tissue very thick one in the area of the common canaliculi. I use a horizontal cut and imitate the scar tissue like a superior flap and rotate the superior flap up and try to do it with the suturing of the superior flap upward to the nasal mucosa superiorly. Thoughtful make the well approximation, because if we do not do the suturing of this on the superior scar tissue, we call pseudo flap suturing this one, they have very high percent that scar tissue will rotate downward by the gravity. So in this case, that the thick scar tissue at the common canaliculi, the combined flap or the superior flap alone would really helpful and have the indication. Because if you don't do that, sometimes the gravity make the fail again. Even though you put the silicone tube also. And the one technique that you can use is to see the patient very often. Every 1 week, every 2 weeks, and clean the nose properly. If you can see postoperatively weekly, then you see the granulation, you see the scar tissue, you just clean it, suck it, and inject the steroid periodically, weekly, something like that. That can help for improving the success of the revision case. So post-endoscopy, post-traumatic dacryocytosis, this is another challenging, because this is not like a conventional one, because how to deal, because the degree of bone gonna be changed because of the displacement. Sometimes the inferior orbital rim gonna be displaced to be the area of the frontal prostate in front of the lacrimal sac. That's gonna be very difficult. Sometimes the space of the nasal, because if you have the panfacial bone fracture, all of the maxillar bone fracture and backward posteriorly displacement, so the whole face is collapsed. So the nasal cavity is so narrow, and the scar tissue at the common canaliculi, especially if you have the tear canaliculi, gonna be very tough one. So in this case, they have the panfacial fracture. After this fracture, about a year, he developed really bad infection. So if you do not do the CT scan, if you not learn about the 3D, sometimes you go in, have you ever go inside the surgery and you could not remove the bone? That's gonna happen. And I have the trick to deal with this one. If you have this one, try to put the CD in the computer and learn this one first. And limitation by the endoscope, because the displacement of the surrounding bone and the nasal cavity and the scar tissue. And this is if you want to learn, if you use a Macintosh or Windows, you search about the DICOM software for evaluate the CT scan, and they have the many free download. And I use the Macintosh. It's very practical to use this one. And when you download this one, they have the mode called surface rendering. When you put this one in 10 seconds, the whole thing come up with the 3D. Is much better than in the hospital bed CT scan, because the CT 3D in the hospital, they fix position. They not allow you freely to mobile and rotate 360 degrees and learn the anatomy. I always have the very difficult case like that. The night before the surgery, I put the CT like that. I learned a lot. I remember the whole configuration of the bone and the whole fracture in my brain. And then when I go to the surgery, I don't go simply. I use a retinal ripple to put from the upper punctum to the canalicular line and put the pen and tip of the retinal light part to indicate the position of the bone. If we don't do like that, sometimes we could not find the position of the removable bone. Sometimes we remove the nasal mucosa too much. Sometimes we go to the wrong side, so we move the bone too big. That's a problem. That's a very practical point that we apply to use. And the trick is when you use an illumination technique, you ask the retinal light part and put this one, or you are the beginner, you want to learn how to do endoscopy, you can apply this technique. And it's all free because the retinal surgeon uses this one for one time and they just throw away. And you put that one and close the light of the operation room so you can see. You just a simple crescent launcher opening like that. And once you have the one of couple punch, you can open this one and you can go to do the routine conventional endoscopic DCR, and we can overcome of the difficult case easily. That's a point. So this is an example of the case of the panfacial fracture and a very tough case. This is in the case that happened in my beginning part of my practice. In that moment, I don't have this concept. I have to revision for her for a couple times until I got the concept that I need to use the CT to evaluate this one. So this is the way we learn. So this one probably we have seen this one. Okay. By this moment, any question for our colleagues? Any question? Tommy, any comment for the revision case?
Yeah, I run a lot. So my specialty is orbit and not for this year. So I run a lot. Thank you.
Okay. Any comment, please?
I'm also actually learning a lot, and it's actually very encouraging that what you are doing actually is what we are all doing, but you've given them, a different kind of structure. Your 45-degree test, I do that. It's just that when I put in my Bowman probe, I just need to tell my fellows, don't hit bone. If you know you're not hitting bone, you should be fine, and then that's enough to be ruled out. That illumination technique, my ex-boss used to do that, and we work towards the light, and we take away all the bone.
Right.
So I think we are all applying that same concepts, but I'm taking away that bit about suturing the flaps, and especially for the revision cases, and I can see how gravity is going to make it fail again. So thanks for that, actually.
Right. Okay.